Hello, good evening friends. So today we'll be discussing about squamous cell carcinoma, and for these notes you can just go to the description and download these notes. These are very wonderful notes and will be helpful for MBBS surgery exams. Along with that, it will be also helpful for MS and DNB final year exams. Also, it can be used for SS exams and SS final exams. So, and I would like to thank Dr. Chandana Shri Ma'am for sharing these wonderful notes with us, and these are very helpful. Thank you, ma'am. So, we'll start with squamous cell carcinoma. So, these are squamous cell carcinoma, the malignant tumor of the epidermis and its appendages like the hair follicle and all, and these show maturation towards the keratin formation. Arises from the stratum basalis or germinatum, that is the lowermost layer of the epidermis, and IHC, immunohistochemistry, these demonstrate cytokeratin 1 and 10. Epidemiologically, these are the second most common cutaneous carcinomas after basal cell carcinoma and most common cause of death from non-melanoma skin cancer. Males are more commonly affected, and middle-aged and fair-skinned people are more affected. So what are the risk factors? UV radiation. So it is the cumulative radiation, sun exposure and the damage. That is the prolonged period of exposure. Sun exposure with incidence, proximity to the equator, that is we know already. Poor treatment for psoriasis is a risk factor, and tannin booths. Then ionizing radiation like radiotherapy and all, immunosuppression for solid organ transplant, it is increases the risk by 100 times, more aggressive and more recurrence. Chemicals like hydrocarbons, coal or arsenic. Genetic skin syndromes, genetic skin cancer syndromes like xeroderma pigmentosa, albinism, Muir-Torre syndrome, dystrophic epidermolysis bullosa, and Fanconi's anemia. So these are five. We'll revise: xeroderma pigmentosum, albinism, Muir-Torre syndrome, dystrophic epidermolysis bullosa, and Fanconi's anemia. Chronic inflammation due to various causes like chronic sinus tract, pre-existing scars, burns, osteomyelitis, vaccination points, and Marjolin's ulcer. HPV 5, 16 and 18 can cause anogenital SCC, and these are the some disorders like epidermodysplasia veriformis, which is caused by HPV 5 and 8, whereas verrucous carcinoma HPV 6 and 11, and periungual SCC, that is due to HPV 16. So all these can cause anogenital SCC. So we'll see the pre-malignant precursor lesions in detail. That is one, cutaneous horn. It is dense cone of hyperkeratotic epithelium. बहुत सारा जमा हो जा रहा है hyperkeratotic epithelium. कहाँ पे दिख रहा है? sun exposed area में, old individuals में. Then it generally develops from warts and seborrheic keratosis or pre-malignant lesion like actinokeratosis or SCC in situ. Malignant lesion like SCC even. So 15% of the cutaneous horns have invasive SCC at the base, so we have to be careful. Then we come to actinic keratosis, which have the potential to develop into SCC and found in the sun exposed area like the face, scalp, ears and lips. These are erythematous or brown ill-defined patches, sometimes skin colored also, and have some adherent scales. These are areas of permanent skin damage due to sun and show disc keratosis, that is partial thickness cellular atypia, and there will be subepidermal inflammation, that is important, and there will be intact basement membrane. So 4 points for actinic keratosis, which is important: disc keratosis, which is partial thickness cellular atypia. There will be subepidermal, below the epidermis, inflammation and intact basement membrane. Then we come to the third point, that is keratoacanthoma, where we see rapidly growing nodular tumor exhibiting symmetry around the central keratin filled crater, a crater hole which is surrounded by nodular tumor, which is rapidly growing. Sometimes may regress spontaneously. Males are more commonly affected. 2:1 is the ratio. Face and limbs, it is commonly seen. Chronically sun damaged skin, fair skin areas, commonly seen in 50 to 70 years of age group. HPV in hair follicle during the growth phase is seen. Smoking and chemical carcinogen exposure. Differential is an anaplastic SCC and it is recommended to get it excised. निकलवा लेना better है. Now we come to Bowen's disease, that is squamous cell carcinoma in situ, develops as a full thickness dysplasia or hypertrophic actinic keratosis that we had seen ahead. So these are slow growing erythematous scaly plaque or any mucocutaneous surface on any mucocutaneous surface, and these are also known as erythroplasia of Currat when it is on glands. It is treated with topical 5-fluorouracil or imiquimod, that is the immunotherapy, chemotherapy, surgical excision with 4 mm margins at least, and Mohs micrographic surgery. SCC has higher metastatic potential than BCC, so you have to always take care of the nodes if they are involved, and you have to be suspicious. Most common site of Mets are the regional nodes, and distant could be bone, brain, lungs, and in head neck even parotid. So the anatomical distribution, the cheek, nose, ear, preauricular area, neck are the most common. Head neck involving the 80% area. Then we have hand, trunk, leg, and anus. So we have the anatomical distribution in three zones, that is the H zone, that is the middle part, M zone, that is the surrounding part, the cheek, scalp and the neck region, and the L region, that is the extremities, chest, shoulder and limbs. So any size in the H area, that is the central area, the nose, eyes, lips and all, any size of tumor, it will be high risk. For tumor involving the M area, that is the scalp, cheeks and the neck, size will be more than 10 mm or 1 centimeter, and for the extremities, shoulders, it is more than 20 mm, that is 2 centimeter. So all these lesions will be high risk. Then we come to macroscopic features. So these appear as smooth and nodular, verrucous like cauliflower like, papillomatous, like a papilloma, or ulcerative, that could be due to squamous cell carcinoma, and over time all these lesions ulcerate and have a everted edge with surrounding induration. Everted edge and surrounding induration. We have to differentiate it with pearly lesion in this basal cell carcinoma, which is most common. Here it will be everted edge, but it will not be pearly. Microscopy, it will be squamous cell epithelium invading the dermis, irregular masses, and it will be onion like peels. Also, one extra point which I would like to share is there is a prickle cell appearance. So prickle cell appearance and onion-like pattern due to the irregular mass of squamous cell invading the dermis. Then we have immunohistochemistry with cytokeratin 1 and 10. Then we will see the Broders grading, which is the differentiation. So it is 1 to 4. If it is 1, it is well differentiated, and there will be less than 25% undifferentiated cell. In moderately well differentiated, it will be 25 to 50% of undifferentiated cells. In 3 is poorly differentiated, it is 50 to 75% of undifferentiated cells, and anaplastic more than 75% of undifferentiated cells. Now we'll go ahead with prognostic factors. So the depth of invasion, if it is less than 2 mm, it is less, it can have good prognosis. If it is more than 6 mm, it can have bad prognosis, as 15% of these patients will have metastasis. Diameter more than 2 centimeter will have poor prognosis. Grade, the Broders grading, higher the Broder grade, worse is the prognosis due to more number of undifferentiated cells, that is poorly differentiated cell. Lymphovascular or perineural invasion will have poor prognosis. Sites such as lips, ears have higher local recurrence rates, that is the H area. the central area. Extremities have poor prognosis than trunk. Etiology is from burns, osteomyelitis, sinus, ulcer, irradiated skin have higher metastatic potential, and immunosuppression, especially after the solid organ transplant, have greater chances of invasion. Then staging, TNM staging. So what are this TNM staging? Where TIS is in situ, T1 less than 2 centimeter, T2 is 2 to 4 centimeter, T3 more than 4 centimeter or having minor bone invasion, deep invasion or perineural invasion, T4A cortical bone invasion or marrow invasion, T4B is skull base invasion. N1 is node size less than 3 centimeter without extranodal extension. Node 2 is size less than 6 centimeter and node 3 is more than 6 centimeter or extranodal extension. M1 is distant metastasis. So stage grouping of TNM here will be T1 will be stage 1, T2 will be stage 2, T3 will be stage 3, N1 with any T 1, 2 or 3 will be stage 3. Stage 4 is N2 or N3, T4 or M1. So these will be stage grouping of squamous cell carcinoma. So we'll be evaluating with history, then head to toe examination. We'll check the primary and the nodal basins, CT and MRI for depth of invasion and nodal evaluation. MRI is more sensitive for nodal evaluation. It has more specificity and CT has more sensitivity. Biopsy will go ahead with full thickness punch biopsy or excision, or we can also go for shave biopsies. Treatment will be wide local excision, and we will go for low risk lesions with 4 to 5 mm of margin, and these low risk lesions are less than 2 centimeter lesions, and 10 mm margin for high risk tumor. Schwartz and Bailey has given 10 mm margin, that is 1 centimeter for high risk tumor. That is tumor involving the central part of face. If involving the scalp, cheek or neck, when the size is more than 1 centimeter and extremities and trunk more than 2 centimeter. So these will at least have to keep 1 centimeter of margin or 10 mm margin. If we have positive margin on wide local excision, we'll go ahead with Mohs micrographic surgery or re-excision. If surgery is not feasible, we'll go ahead with radiotherapy. Mohs micrographic surgery in selected cases, its advantage being spontaneous histopathological examination to go ahead with further resection if needed. Only disadvantage being more amount of time needed for the surgery. This is especially useful for recurrent cases, large lesions in the vital areas, the central part of the face, that is the H area, curettage and electrode dissection, radiation, primary, adjuvant, local therapy with topical 5-fluorouracil or imiquimod. These are especially useful for pre-malignant or in situ lesion. Also, we can go ahead with photodynamic therapy or cryotherapy. Management for nodal lesion, if it is operable in the head neck especially, then we'll go for neck dissection followed by radiotherapy. If it is inoperable, we'll go for straight away radiotherapy. Then for systemic therapy, these will be adjuvant or in cases of locally advanced, inoperable or metastatic stages. Systemic will be cisplatin with 5-fluorouracil or carboplatin, EGFR inhibitors like cetuximab and semiplimab, that is anti-PD-1 inhibitor antibody. So this was all about squamous cell carcinoma. Hope it has been well understood, and keep studying, keep growing. Thank you for watching and listening. Keep studying, keep growing. Please like, share and subscribe. We'll see you in next video.